This will be recorded too, so if anybody wants to listen to it afterwards, you guys can as well.
All right, so we'll go ahead and get started. So today's topic is management of Staph aureus bacteremia, and I'm Dr. Horn.
And I'm Dr. Vivekanandan.
And thank you all for being here. So we like doing this webinar and going over these topics, and we're happy to go over any topics that you have. This is kind of a series where we can cover topics and come back to them and really just go over antibiotics and infectious diseases and antimicrobial stewardship with really any of the topics that you'd like us to discuss.
We were going to talk about bacteremia in all general, but it's such a large topic, so we wanted to kind of divide and slowly conquer little by little. But if you guys have any questions on gram-negatives or fungemia, please feel free to ask us. So we'll get started. So one of our big philosophy is don't ignore Staph aureus in the blood. So even if it's 1 of 2 blood cultures or 2 of 2 blood cultures, if Staph aureus is in the blood, it's never considered a contaminant, and it's always considered real, and it should be evaluated and treated accordingly. And another interesting point is also when we get Staph aureus in the urine, it doesn't matter if it's MSSA or MRSA. Usually, the path for staph to get to the urine is usually transient bacteremia. So most likely the patient had a bacteremia and then got into the urine. Unless the patient recently had a urological procedure or had a Foley catheter placed, cystoscopy, recent straight cath, TURP, chronic indwelling suprapubic catheter, then it could be a colonization. But for the most part, if you find a healthy young female comes into the inpatient and she has staph in the urine, it should be worked up as does she have other sources of infection? Does she have bacteremia? So we should get blood cultures and we should consider treating. And you were saying earlier also it's important to kind of look at symptoms too in those cases.
Yes, and I think this is a really good point to make because oftentimes we'll get consults and you'll have bacteremia with Staph aureus in the blood, and then will also be growing in the urine. And the clinicians that we talk to, they'll say, oh, it must have been gone from the urine and then gone to the blood. But actually, it probably went the other way around, and that's what the evidence shows, is it probably went blood and then went into the urine. So if it's in the urine, you'd have to high suspicion it came from the blood.
Yeah, because Staph aureus is a skin flora, but it's not a urological flora. So you don't usually find it in your vaginal or in your groin area. So if you do find it in the urine, then high suspicion for was there a bacteremia and other source.
Yes, so if a patient comes in and they have it in the urine, they might say, oh, a week ago I was having a fever. So then you'd say, oh, in my mind, I think that, oh, a week ago they might have been bacteremic, and that's how it got into the urine. Is that what you think?
Yeah.
Yeah. So if it's in the urine, consider checking the blood, make sure that they don't have any bacteria in the blood. Also.
And then also, if you cannot find any other sources, no urological procedure, then I would consider treating that patient minimum 7 to 10 days to make sure we cover our bases. So control the source, removing the infected catheter and prosthetic device. So if you don't remove prosthetic device or catheters when we have Staph aureus bacteremia, it's associated with prolonged bacteremia, treatment failure, and also can end up with death. Retention of prosthetic material is associated with increased likelihood of relapse. And Dr. Horn is going to touch base about this a little bit later. And the main reason is Staph aureus causes this material to form called biofilm. So anytime you have a central line catheter, you have an ICD, pacemaker, any type of prosthetic device, and you have Staph aureus bacteremia, it will tend to form this biofilm, and it's very hard to get rid of the bacteria there, and high risk for relapse and treatment failure. So controlling of the source is extremely important. I don't know, did you have that one?
Oh, no, that's great.
And then also control their source. Evaluating for metastatic infection is very important. A lot of times when we take care of Staph bacteremia, it's really important to do a really good physical exam of the patient, because they might come with just Staph aureus bacteremia, but more we talk to the patient, then they will say, oh yeah, I have this like lower back pain I have had for the last 2 weeks or a week. Or they might say, oh, the shoulder pain just showed up like 3 days ago. And the reason it's Staph aureus bacteremia loves to seed in your spinal area, epidural space. It loves to seed in joint spaces, and also, of course, endocarditis and abscesses. So we tend to, when a patient has Staph aureus bacteremia, really do a good physical exam, get a really good history, and make sure we evaluate all those high-risk area to make sure we don't miss other sites of infection.
Yeah, and this is why we wanted to focus so much on Staph aureus bacteremia, is that it'll go places and stick places, it'll seed places. So even if you're treating it appropriately, they might all of a sudden have pain in their knee or in their ankle, in their back. They might have an abscess. So this is really why we wanted to focus on Staph aureus bacteremia and really make sure that it's treated really aggressively, is because even if you're treating appropriately, you can still have it going places, seeding and causing problems in other locations. So it's really important to treat it aggressively and for a long duration.
And another trick always is when they complain, a lot of times they have back pain, lower back pain. When you image the lower back area, if you just stop at the lumbar area, you'll miss the abscess that is below. So the Staph aureus loves to cause abscess in your lumbar spine area. But then what it does is goes into your psoas muscles, which is your upper buttock area, and hides abscesses there. So it's really important to get a nice spinal imaging with your psoas muscle and also image, so you can get a better picture if you're worried about lumbar area issues.
Yes, and that's a really good point. There are articles that say that the top mistakes when treating bacteremia, and one of them is when you image, that you don't do enough imaging.
Yes.
So that's a really good point, is that even if it's, say, at a certain level of the back, you should go a little bit higher and a little bit lower. And I've seen that mistake. It's understandable to do that, but once you've seen that mistake before, you can understand that it's really important to image more of the back than you think is needed. Yeah.
And then what's also important, if you guys look at this number, so if you have Staph aureus bacteremia, even if it's just 1 of 2 blood cultures, the chances of you having endocarditis is about 11 to 31%. So it's such a wide range. So that's why, as ID physicians, we're always recommending, if you have Staph aureus bacteremia, to get echocardiogram to make sure we do not miss endocarditis.
Yes, and even going back to the first slide, that even if it's just 1 of 2 blood cultures are positive for MSSA or MRSA, you should still do an echo. You should still treat it very aggressively, and not as a contaminant. But sometimes providers will say, oh, it's just 1 of 2. I don't really need an echo, do I? And so I would say yes. If I were the patient, I would want an echo. I'd want to make sure I don't have endocarditis. And then as far as what type of echo, whether it's a transesophageal or transthoracic, that's where the transthoracic can miss some that the transesophageal won't miss. So every couple of years they'll come out with another study saying how often the transthoracic misses endocarditis, and I want to say it's around 8% or so.
Yeah, so they say that transthoracic echocardiogram only sensitive specific like 75%, but esophageal is like 90% sensitive and specific. So that's why us ID doctors always love esophageal, but not all patients can get it, because if they're unstable to have one, or they have esophageal stricture. So in that case, at least getting a transthoracic minimum is required for these patients.
Yes, and different ID doctors, they came out with a survey and they asked, do you say they need a transesophageal or is a transthoracic okay? And different ID doctors will make different recommendations, but if I were the patient, I would want a transesophageal.
Yes.
So since it's pretty straightforward to order one and get one in our facility. Some cardiologists will say, oh, you have to have a transthoracic first, and if it sees something, then get a transesophageal. Or if it doesn't see anything and you have high suspicion, then get a transesophageal. So whether it sees something or not, you're still going to get one. So
the thing about transthoracic is it can look at some of the heart valves, but not really the pulmonic valve or the tricuspid valve as much as the mitral and aortic. And the other thing about transthoracic echo is that it might, but if you have abscess in your heart, it's not very good at picking it up. But transesophageal is really good at picking up those little details.
And then this slide is document clearance. So you want to show that the blood is clear of all bacteria. So repeat blood cultures recommended at 48 to 72 hours after the initial positive cultures to document clearance of the bacteremia. So you want to, once you have positive blood cultures, whether it's 1 of 2 or 2 of 2 or growing MSSA or MRSA, then repeating blood cultures after being on appropriate therapy for 48 to 72 hours. And then you want to make sure it's no longer in the blood. And then when you see that it's no longer in the blood and you documented clearance, that's when I start my clock as far as how long to treat. So I'll say it's from the first negative blood culture. So the first blood culture that has no growth, then you'd say that's the first day I'm going to start. So I'll say if I'm going to treat for 2 weeks, that would be day 1. And then positive repeat blood cultures are a predictor of metastatic infection or endocarditis. So if you keep having positive blood cultures, even though they're on appropriate therapy, it would give you higher suspicion that they have endocarditis or they have a source that's not controlled. So they might have a large abscess somewhere, or they might have infected hardware or something where the bacteria is continuing to grow and continuing to get into the blood. And then repeat blood cultures, positive, do not repeat more frequently than 48 to 72 hours. So, and the reason that's there is because sometimes people will, right when it becomes positive, they will check it immediately, and then they'll check it again the next day. And then if they check it really quickly, it's more likely to grow. And also, it becomes scary because they'll say, instead of having 2 of 2, then they'll say, oh, we've had repeat blood cultures for 3 days straight. Well, you need to give the antibiotics some time to work, and time to clear.
The time to work a little bit for the antibiotics is important. Yes.
Yeah, and then it gets really scary when they say, oh my God, we've had positive blood cultures for 4 days straight.
And also so, it sucks because our patients get phlebotomized and lose so much blood too. So 48 to 72 hours repeat culture is good. Yeah.
And then treat with the right drug at the right dose. So patients on the most effective therapy as soon as possible. So for MSSA, you would want to use cefazolin or oxacillin or nafcillin. And MRSA, vancomycin is really the drug of choice. So we'd recommend giving vancomycin, and for bacteremia, a trough of 10 to 15 would be okay.
Yeah. You know, a lot of times what we see is if the patient is stable and they're just having bacteremia, a trough of 10 to 15 is good, because, a lot of time our elderly patients, when we push the trough to be around 20, that's when they get into acute renal failure and all the other rest of the complications. So a lot of studies, if you do a trough of even 15, that should be plenty. There's no need to go to 20 unless they have meningitis or they're crashing in the ICU, severe sepsis. In those cases, it's reasonable to do 18 to 20. But most patients, like you were saying, 10 to 15 is perfect for MRSA infections, bacteremia.
Yeah, for straight bacteremia, if you push for a higher trough of 20, you're more likely to have kidney injury, and the outcome as far as the bacteremia is the same.
Yeah.
So the outcomes, it doesn't improve getting rid of it from the blood, but it hurts the kidneys and gives you more issues from.
Then you had dialysis, prolonged hospital stay, and all the other stuff. Yeah.
Yeah, and then so MSSA, you want to use cefazolin or nafcillin or oxacillin, and then we're going to see in a second that cefazolin is actually superior to oxacillin and nafcillin. And here this is the comparative evaluation of the tolerability of cefazolin and nafcillin for the treatment of Staph aureus. So if cefazolin and nafcillin are essentially equal in killing the bacteria, then the question is, which one can the patient tolerate better? can they tolerate cefazolin or nafcillin better? And it comes down to cefazolin's better tolerated by the patient. Because once, let's say the patient has a rash on cefazolin or a rash on nafcillin, if you have a rash with nafcillin, they jump to vancomycin. And then you're going to be comparing vancomycin versus a beta-lactam. So if you're trying to compare cefazolin and nafcillin, if more people get a rash and don't tolerate nafcillin, and then they have to start on vancomycin, then you're comparing cefazolin with vancomycin. And really, patients have better outcomes when they have either cefazolin or nafcillin compared with vancomycin. And so this is a common question, and as far as the residents and fellows that we work with, a common boards question is, what's the best drug for MSSA? And they'll put vancomycin and cefazolin there. And you have to know that cefazolin has a lower mortality, better outcomes, lower length of stay.
Yep.
It's just all around better. So sometimes we'll talk to providers and the patient has MSSA and we'll recommend changing vancomycin to cefazolin. And the provider will say, oh, well, it doesn't matter, they're already covered. Kind of, but not really. So because they have such better outcomes, you'd want to be on cefazolin or nafcillin.
So in my opinion, beta-lactams are always better if you could use them compared to vancomycin. So like in an MSSA, when you can't use a beta-lactam, definitely go with the beta-lactam. And then when it comes to tolerability, if the patients don't have all these reactions to nafcillin rash, sometimes renal injury, liver injury, cefazolin, they don't have all those reactions. So much better to just go with cefazolin, and they do really well. Another really nice thing about cefazolin in a dialysis patient, a lot of people ask us this question. It's really nice if a dialysis patient needs long-term cefazolin therapy. You could do cefazolin after dialysis Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So you would give 2 grams, 2 grams, and 3 grams. So in those patients, you're not stuck putting another line in. Just like vanco, you could do cefazolin after dialysis as well. So that's really convenient.
Yeah, so 2 grams Monday, 2 grams Wednesday, 3 grams Friday. Yeah, so that's a great way to do it. And then they wouldn't need an extra line.
Yeah.
And then alternative antibiotics for MRSA. So the preferred first line is vancomycin for MRSA. Now, if the MRSA MIC is 2 or greater, there's a high risk of failure and a higher mortality. So we would recommend not using vancomycin if the vancomycin MIC is 2 or greater. So we'd switch to an alternative antibiotic. You can switch to daptomycin or linezolid or ceftaroline. Ceftaroline is a 5th generation cephalosporin, and it's the only cephalosporin that works against MRSA, but it works very well. Not all facilities carry ceftaroline, but in cases where the MIC is 2 or greater, or they're having a lot of kidney injury from the vancomycin, then ceftaroline is a really good option.
And then if the patient's cultures are not responding about 5 to 7 days, then you could consider alternative therapy too. The MIC part is really important to pay attention to, because a lot of times, that's what we always teach our residents and fellows. It'll show up on the lab report as it's susceptible, because lab guidelines, it's only resistance after 8. So it's 2 still would show as susceptible. But we know this is called MIC creep. We know if for MRSA greater than 2 MIC, bad outcomes for patients. So definitely that's important to kind of call and talk to the lab and get that information.
And sometimes one kind of common question we'll get is that the patient isn't clearing their blood for several weeks. So if they're not clearing their blood, then one option would be daptomycin plus ceftaroline. And this we'll get into in the next slide. This is called the seesaw effect. So this is when ceftaroline combined with daptomycin, and it's called the seesaw effect because the ceftaroline kind of changes the charge on the
Bacterial cell wall.
On the cell wall, and then helps get the daptomycin in. So it'll kind of seesaw the daptomycin in with the charge. So using ceftaroline plus daptomycin helps clear the blood a little bit faster than they otherwise would have cleared.
So in those refractory cases, we end up using 2 different agents. This slide kind of talks about echocardiogram again. We already kind of talked about it, but the main emphasis on this slide is transesophageal echocardiogram is preferred over transesophageal transthoracic echocardiogram because of the sensitivity and the specificity of identifying infection. TE is the test of choice for all patients with prosthetic valve, pacemaker, ICD, or persistent bacteremia. Follow-up blood cultures are positive. Like we talked about, in some patients it's kind of hard to do, but this is the test of choice. Failure to treat for adequate duration results in increased rates of relapse and tends towards increased treatment failure. So with staph bacteremia, it's kind of important to know different scenarios. You're going to need different duration of therapy. So what we call uncomplicated staph bacteremia is when somebody has Staph aureus in the blood, but there's no other sites of infections. In that case, you could do 2 weeks of therapy, either if MRSA vancomycin, if MSSA cefazolin, like Dr. Horn was saying, from the day of negative culture, first negative culture for 2 weeks. But we call complicated Staph aureus bacteremia if they have staph bacteremia with cellulitis, wound infection, any other sources, then it automatically becomes complicated. Another important thing to know too, if somebody has persistent bacteremia, so when you repeat the blood culture and it's still positive, that automatically falls under the complicated category. So for all those patients, you're going to need at least 4 weeks of therapy. And then if you have endocarditis or osteomyelitis, then the duration is even longer. It's 6 to 8 weeks of therapy. So that's why it's really important about what are the other sources, and then we could kind of go from there about the duration.
No, that's good.
Additional antimicrobial agents. We never give gentamicin for Staph aureus bacteremia. It really doesn't help clear the blood. It actually ends up causing more harm to the patient. It ends up causing more nephrotoxicity, ototoxicity in our elderly patients. So we seldom ever give gentamicin as a synergic agent for Staph aureus bacteremia. Rifampin, there is a role. There have been some studies that they did when they looked at prosthetic joint infections in the knee with Staph aureus, and when they gave rifampin, what it did is it helped. The rifampin basically broke through the biofilm that Staph aureus creates. So the other antibiotic like vancomycin was able to enter and kill the bacteria. So in our current guidelines, for prosthetic heart valve, pacemaker, prosthetic joints, you can't use rifampin as a synergy agent together. But a good point here is we never use rifampin alone because it causes resistance rapidly in a couple of days. So it always given with another Staph aureus agent.
Yeah, and that goes for like a prosthetic knee infection that you're going to give chronic suppression. So you would never give rifampin alone as a chronic suppressive agent either. So, and that's a favorite test question. Sometimes they'll say, what do you want to give? And then they'll say, do you want to give Bactrim or rifampin? And then they'll give some other options. So Bactrim might be a good option for chronic suppression, but you'd never give rifampin alone, or else it'll develop resistance and it won't work. Yeah. And that's the same here. You would never give rifampin alone. You'd always give it in combination. Oh, good. So this is, I thought this was worth putting here. These are steps to prevent central line infections. So there aren't very many ways that we know of to prevent central line infections, but these are the ways that are well proven and well shown to make a difference. So good hand washing, wear sterile gloves and hat, and when the essentially sterile procedure when placing the central line. Clean with chlorhexidine. So chlorhexidine is the agent that's the best for preventing infections. And then remove catheters when they're no longer needed. So as soon as you don't need the central line anymore, you can take it out. But these are the best methods to prevent central line infections. And this is catheter and prosthetic device management. So recommend removing all prosthetic devices. The retention of indwelling foreign bodies has been associated with an 18-fold increase in the risk of relapse. So if a patient does have any kind of central line, we'd recommend removing it if they have bacteremia. Otherwise, it will seed the line, and then it will be harder to clear if you can clear it at all. So sometimes when we have a patient with bacteremia, with MSSA or MRSA, we'll have a new intern that will say, oh, they'll need a line. They're going to go home with a line, so they'll have it placed immediately before the patient has cleared their blood. And so we'll repeat blood cultures to document clearance of the blood, and if it continues to be positive, then that line will just need to come out because now it has stuck to the line, and it's just going to stick there with a biofilm and not be able to clear the blood anymore. So it's kind of a
and
common
it's
problem.
scary, 18-fold increase in risk of relapse. So
Right.
that's why we always emphasize if you could take out the line and stuff, it's really important.
And so we want to document clearance of the blood before placing a PICC line or any kind of lines that the patient's going to go home with. And here, this is catheter and prosthetic device management. So this is a picture of the biofilm. So the biofilm will attach both on the outside. Well, let's see, both on the outside and on the inside. So here's the outside of the line, and this is in the bloodstream. So you can see it's attaching on the outside, but on the inside as well. So patients that have port or PICC lines that are there for an extended period of time, the bacteria will grow on the outside or the inside, and so we'd recommend removing the line would be the first step. So whenever we get a patient that has an infected port or PICC, the first question is always, do they need the line? So if they no longer need the line, just remove the line.
Yeah.
Patients that have ports, they may have been treated with chemotherapy years ago, and the port was left in. And so the first question is, do you need the port? Sometimes if patients, even if they've just recently completed chemotherapy a month or two ago, if you ask the patient, they'll say, I'm not sure. And then what? They'll say that I'm going to be reevaluated with a PET scan or a CT scan in another 6 months to see if I'm going to have more chemo. In those, I really strongly recommend removing the port at that time because they're not even sure if they're going to need it ever again. And if they get recurrent infections from it, it's more harm than good.
And it's so hard to get rid of Staph aureus from a prosthetic site. There are sometimes you could do antibiotic locks, but that's usually for like Staph epi, coagulase negative staph infection and port. Or if you have like a gram-negative bacteria, if you want to do a gentamicin lock. But with Staph aureus, it's really hard to get rid of because, as you guys could see, that big, thick biofilm where the bacteria hides under, it's really hard to get rid of.
So if the patient grew Staph aureus or fungus or Pseudomonas, they really need to have it taken out. Here you can see, this is the biofilm here. It looks like essentially just mucus. And so here's the biofilm. And then down here, here's another picture of the biofilm. You can see it attaches and then grows an extracellular matrix that encompasses it. So usually when people think of bacteria, they think they don't communicate and they're all just out for themselves. But the biofilm development is actually kind of interesting because they work together to make the biofilm. It actually has ways of it keeps the flow of the blood through it. So it keeps the flood so nutrients can come in. And it actually has specifically areas for waste to go out. And it all communicates with each other, which is very interesting. And this is the same, biofilms are the same things that you find in your sink. When your sink is full of gunk, those are biofilms. The same stuff that's on your teeth, those are biofilms.
Yeah.
So it's actually kind of interesting. But you can see here it accumulates and it's hard to get rid of without treating for either an extended period of time, drugs that can break into it and get into it, like rifampin, or just removing it is the best thing. Here, this is catheter management. So short-term catheters, you can remove if possible. Long-term catheters, they should be removed unless there's a major contraindication. So sometimes if a patient needs to be on pressors in the ICU, we really recommend removing it if possible, because once it's removed, sometimes the patient gets off pressors very quickly and they do very well. But if they can't be removed, sometimes you just have to wait a little bit longer until it's the patient's a little bit more stable to remove it. Let's see. And then here, this is kind of illustrating a PICC line, and it shows where you can get the infection from. So the skin organisms, the skin can cause infection here at the site. Contamination from the hub, so if it's not cleaned well enough when it's used, and contaminate infuse state. So that's kind of, that's more of a test question than one we see in real life.
And I think the reason we're talking about lines and stuff is like the most common cause of line infections that we see is either it's Staph aureus infection or it's coagulase negative staph infection, which is like staph epi. So, and you know, this, whenever patients get Staph aureus infection from a line or a port, it's kind of devastating, you know, for the patient, all the procedures. So I think it's really important to like place the line properly, sterile techniques, and also maintaining the line is really important.
So here are the conclusions. Always repeat blood cultures for Staph aureus to document clearance of the blood. It's never considered a contaminant, even if it's just one of two. So it really shouldn't be ignored. I would say not to consider fungus a contaminant either. Yes. So even one of two fungus, sometimes we'll see written in the chart that the patient's not symptomatic, so they're not going to treat it. I would not.
That's a really good point, because most of the time the fungus that's in your blood is, majority of the time, it's Candida species. And anytime if anybody ever sees fungus in the blood, it's never a contaminant. And if you guys want to empirically put somebody on a therapy for fungal until you know better, you could always do micafungin, because there's lots of different species of Candida and they're more resistant to fluconazole, so I think that's reasonable. But echinocandin is reasonable. But yes, Staph aureus and fungus is never a contaminant.
Yep. Yeah. And then MSSA, treat with cefazolin over nafcillin. So really either one is better than vancomycin, but cefazolin is better tolerated than nafcillin. So it's the drug of choice. And MRSA, vancomycin is what is recommended. Echo is recommended for all Staph aureus bacteremia. MRSA, MSSA, you'd want to make sure that they don't have endocarditis. And then investigate for a source of infection. So you always want to see if you can find a source to help control the source. And once it's considered source controlled, it's much easier to clear and to treat. Duration is determined by the source. So if they have endocarditis, the duration is set by that. So it's a longer duration if you have endocarditis than just straight bacteremia, or osteomyelitis. Yeah.
And then just remember to always kind of pay attention to that MRSA, MIC for vancomycin too.
Yep.
If it's more than two, use a different agent as well. I think that's all we had, talking points, but we are more than happy to answer any questions. If you guys want to text in or just talk to us over the video.
Yes, if anyone has any questions, please feel free to unmute yourself and ask any questions that you have, or type in the questions. We can see anything that you type. We didn't really cover gram-negative bacteremia. Gram-negative bacteremia really, it clears a lot more quickly than Staph aureus, and patients recover quicker. And there are recent articles saying that you don't need to repeat blood cultures to document clearance.
Yeah, and what we mean by that is like a lot of the common gram-negatives, like, you know, E. coli, Proteus, the common urinary bugs that cause bacteremia, transient bacteremia, those are pretty 7 to 10 days. You don't have to repeat cultures. But of course, if you get Pseudomonas in your blood of Acinetobacter, then that's complicated. It's a different story. But common urinary bugs that shows up in the blood, 7 to 10 days, don't have to repeat blood cultures.
Right. And one of the reasons it's not treated, you don't need to worry about treating it as aggressively, is it doesn't stick places like Staph aureus. You won't get paraspinal abscesses as much from gram-negative. So, I mean, you wouldn't see it from E. coli or something like that.
It can happen, but it's very rare.
Right.
Very rare.
It's much more rare,
Yeah.
right? Exactly, than Staph aureus.
We have a question. When using cefazolin, do you use 2 grams or 1 gram Q8 hours? We use 2 grams Q8 hours for bacteremia and complicated cases. A lot of the places we're going away from 1 gram because it's lower dose, and our patients' BMIs are higher. So especially if it's bacteremia with Staph aureus, we end up using, if the kidneys are able to handle, we are using 2 grams Q8 hours.
Yes, and I think that's a great thing
Yeah.
to do, is 2 grams Q8. Then you don't have to worry about underdosing the
Yeah.
patients. So cefazolin is also used for our pre-op surgery
Yes.
patients. And with them,
Yeah.
we go up to 3 grams.
So if you're over 120 kilos.
120 kilos.
Yeah.
So, and that's something that I would have a low threshold to go up to
Yeah.
3 grams for patients that are
Yeah.
larger than most patients.
When you're repeating blood cultures, are you repeating with 2 blood cultures? Yes.
Oh, this is a good question.
Yes.
So we'd always recommend doing 2 blood cultures. And that's 2 sets.
Mm-hmm.
So aerobic and anaerobic from one arm,
Mm-hmm.
and aerobic and anaerobic from the other arm. So it's important to do 2 blood cultures, because if you grow the same organism in both blood cultures, then that's proof that they were bacteremic.
Mm-hmm.
So if you have a patient where you just get 1 blood culture, then you're not sure so much if it's contaminant or if it's actually in the bloodstream. So now I would recommend you wouldn't say it was a contaminant or something picked up from the skin if it were Staph aureus either way. But let's say you had a coag negative staph,
Yep.
1 of 1, then it's hard to tell if that was picked up from the skin or if they were actually bacteremic with the coag negative staph. If you had 2 of 2 blood cultures with coag negative staph, then that's pretty strong evidence that they were bacteremic with coag negative staph. So I would always recommend getting at least 2 blood cultures.
The sensitivity and your specificity goes up.
Yes.
So it's always important to get 2 of 2 sets to eliminate this contamination question. And then you know it's real, and you'll be able to treat the patient for the right duration.
Yes, that's a really good point.
Yeah.
So if you only do 1 blood culture,
Mm-hmm.
so another question we get is, when is the best time to do blood cultures? And the best time is to do when they have a fever. So if they have a fever and you do a blood culture, really the best time is to do it before they have the fever, but has the best result. But we don't know when they're going to have before they have the fever. So they'll get bacteremic, and then the body will respond with a fever. And the more blood cultures you get, the more likely you are to capture it and identify it, and it is to grow. So the likelihood of growing Staph aureus from only 1 of 1 blood culture is much lower than 2. So you're less likely to identify the organism, get the patient on the right drug. And so blood cultures are also important, because if blood cultures aren't done, then you won't be able to streamline the patient and de-escalate the patient and give the most narrow spectrum antibiotic as possible. So it's good to identify it, and then you know if it's MRSA or MSSA, and then you can target it when the patient leaves the hospital. Yeah.
We have another question. What is the value of procalcitonin in MRSA bacteremia versus repeating blood cultures? So the thing about procalcitonin, that how we use procalcitonin, is it's a prognostic marker, and it's never should be used as a diagnostic tool. So if somebody has it's only been really studied in sepsis and pneumonia. So let's say somebody has MRSA bacteremia, but they're they're doing okay on the floor. If you do not have an inflammatory body reaction, you're not going to have elevated procalcitonin. It'll be 0, but you still have Staph aureus bacteremia. So it's just a helpful tool to have, just like some people might have Staph aureus bacteremia and their white count will be 10, but it's like using all the values appropriately. So I use procalcitonin. If it's elevated, then it's helpful to trend. So let's say somebody's in the ICU, they have MRSA bacteremia, they have sepsis, septic shock. Then if it's at if it goes up to 100, then I could repeat it every other day to see if it's trending down. And I know that if it's going down, patient's getting better. But if it's not elevated, doesn't mean they have infection. You still treat.
Right. Yeah. Procalcitonin shouldn't really be used to say that they have an infection, but more if it's elevated when they come in, trending it and using it to stop antibiotics and shorten the course of antibiotics. With bacteremia, I wouldn't shorten the course of antibiotics for bacteremia.
Yeah.
I would for some, like for pneumonias and things like that. But for bacteremia, really, you give a longer duration because the bacteria that went out to metastatic locations, you want to make sure all of that is killed.
Especially with Staph aureus.
With Staph aureus, I wouldn't use it to shorten the course. That is kind of a unique with Staph aureus. Is wouldn't use it to shorten the course with something that's as serious and as scary as Staph aureus bacteremia. And also with blood cultures, if a patient comes in with either a PICC line or a port, you want to make sure when you do blood cultures, you get one from the line and one peripheral. So you're checking to see if the port or the PICC line has Staph aureus in it, and it's a positive blood culture, and also the peripheral line. And if the port or the PICC grows several hours before, it turns positive several hours before the peripheral line, then you can implicate the line. So it's more likely that the PICC line or the port is the source of infection. Yeah.
But either way, even if your peripheral comes back positive as Staph aureus, but if you have a port or a PICC, you still kind of have to take it out because if you're systemically bacteremic, you're seeding everywhere. We have lots of good questions. Any more questions?
All right, well, thank you very much. If you have any topics that you'd like us to cover or you think of any questions that you'd like us to answer, please either feel free to call us or email us with your questions, and we can call you back or email you and get your questions answered. And I think the next topic that we're going to cover is going to be nursing with antimicrobial stewardship and the nurse's role with antimicrobial stewardship. I think that's going to be a great topic.
Yeah.
So
there was a new paper that just came out, and I think that'll be a really good paper to review and talk about how our bedside nursing is a core member of our stewardship team.
Yes, traditionally they haven't been included, so I think this is a really good topic. So
and then we'll send out a calendar, and if you guys could let us know when you have when it's convenient, and then we could decide a date for July. So we'll be doing that soon.
Yes, thank you everybody for your attendance and your great questions. All right, have a good day.
Thank you.